Hello everyone, welcome to ENT student. I'll be discussing EN 4.7. Elicit, document and present a correct history, demonstrate and describe the clinical features, choose the correct investigations and describe the principles of management of CSOM. CSOM is chronic suppurative otitis media. This competency includes the domain knowledge and skill, is the level of show-how, comes under core competency, and suggested teaching or learning methods include lecture, small group discussion, dope session, and bedside clinic. Suggested assessment methods include written, viva voce, and skill assessment. What is chronic suppurative otitis media? It is a long-standing infection of a part or whole of the middle ear cleft, characterized by ear discharge and a permanent perforation. Middle ear together with the eustachian tube, adytus, antrum and mastoid hair cells is called middle ear cleft. Types of CSOM. Clinically, it is divided into two types. The first one is tubotympanic. It involves the antero-inferior part of the middle ear cleft, that is eustachian tube and mesotympanum, which lies just behind pars tensa and is associated with a central perforation. It is the safe or benign type. Second one is atticoantral. It involves the posterior-superior part of the middle ear cleft, that is attic, antrum and mastoid, and is associated with an attic or marginal perforation. It is the unsafe or dangerous type. Tubotympanic CSOM. Etiology. It is the sequela of acute otitis media, usually following exanthematous fever and leaving behind a large central perforation. This perforation becomes permanent and permits repeated infection from the external ear. Ascending infection via the eustachian tube, infection from tonsils, adenoids, and infected sinuses may be responsible for persistent or recurring otorrhea. Pathology. The pathological changes seen in this type are perforation of pars tensa, which is a central perforation. Middle ear mucosa becomes edematous and velvety when disease is active. A polyp, which is a smooth mass of edematous and inflamed mucosa, is seen. It is protruded through a perforation and is presented in the external canal in most of the cases. Ossicular chain may show some degree of necrosis. Ossicular chain includes all the three ossicles. Tympanosclerosis may be seen, which is scarring of the eardrum. Fibrosis and adhesions are seen, which are the result of healing process. Clinical features include ear discharge. It is non-offensive, mucoid or mucopurulent, constant or intermittent. Hearing loss, which is conductive type, and severity varies but rarely exceeds 50 decibels. In long-standing cases, cochlea may suffer damage due to absorption of toxins from the oval and round windows, and hearing loss becomes mixed type. Third clinical feature is perforation, which is always central. It may lie anterior, posterior, or inferior to the handle of malleus. Middle ear mucosa is seen when the perforation is large. Normally it is pale pink and moist, but when inflamed it looks red, edematous and swollen. Occasionally a polyp may be seen. Investigations include examination under microscope. It is essential in every case and provides useful information regarding presence of granulations, ingrowth of squamous epithelium from the edges of perforation, status of ossicular chain, tympanosclerosis, and adhesions. Audiogram, which gives an assessment of degree of hearing loss and its type, and culture and sensitivity of ear discharge, which helps to select proper antibiotic ear drops, and mastoid x-rays or CT scan of temporal bone. So here mastoid is usually sclerotic with no air spaces, but sometimes may be pneumatized with clouding of air cells. Treatment. First one is oral toilet. Remove all discharge and debris from the ear. It can be done by dry mopping with absorbent cotton buds or irrigation with sterile normal saline. Second one is ear drops. Antibiotic ear drops containing neomycin, polymyxin, chloromycetin or gentamicin are used. They are combined with steroids, which have local anti-inflammatory effect. Systemic antibiotics, they are useful in acute exacerbation of chronically infected ear. Otherwise, role of systemic antibiotics in the treatment of CSOM is limited. Patients are instructed to keep water out of the ear during bathing, swimming, and hair wash. For this purpose, rubber inserts can be used. Treatment of contributory causes. Attention should be paid to treat concomitantly infected tonsils, adenoids, maxillary sinus, and nasal allergy. Surgical treatment, oral polyp or granulations, if present, should be removed before local treatment with antibiotics. It will facilitate ear toilet and permit eardrops to be used effectively. Reconstructive surgery. Once ear is dry, myringoplasty with or without ossicular reconstruction can be done to restore hearing. Coming to atticoantral CSOM, etiology is same as of cholesteatoma, which is abnormal skin growth or skin cyst trapped behind the eardrum. Atticoantral CSOM is seen in sclerotic mastoid, and whether the latter is the cause or effect of disease is not clear yet. Pathology. Atticoantral CSOM is associated with the following pathological processes. First one is cholesteatoma. Next we see osteitis and granulation tissue. Osteitis involves outer attic wall and posterior-superior margin of the tympanic ring. Oscular necrosis, it is common in atticoantral disease. Destruction may be limited to the long process of incus or may also involve stapes superstructure, handle of malleus, or the entire oscular chain. Cholesterol granuloma, it is a mass of granulation tissue with foreign body giant cells surrounding the cholesterol crystals. Symptoms include ear discharge. It is usually scanty but always foul smelling due to bone destruction, and discharge may be so scanty that the patient may not even be aware of it. Hearing loss. Hearing is normal when oscular chain is intact or when cholesteatoma, having destroyed the ossicles, bridges the gap caused by destroyed ossicles. Bleeding, it may occur from granulations or the polyp when cleaning the ear. Signs. Perforation, it is either attic or posterior-superior marginal type. Retraction pocket and invagination of tympanic membrane is seen in the attic or posterior-superior area of pars tensa. Degree of retraction and invagination varies. In early stages, pocket is shallow and self-cleansing, but later when pocket is deep, it accumulates keratin mass and gets infected. Cholesteatoma. Pearly white flakes of cholesteatoma can be sucked from the retraction pockets. Investigations include examination under microscope. All patients of chronic middle ear disease should be examined under microscope. It may reveal presence of cholesteatoma, its site and extent, evidence of bone destruction, granuloma, condition of ossicles, and pockets of discharge. Tuning fork tests and audiogram. They are essential for preoperative assessment and to confirm the degree and type of hearing loss. Mastoid X-rays or CT scan of temporal bone. They indicate extent of bone destruction and degree of mastoid pneumatization. Features indicating complications. These include pain, vertigo, persistent headache, facial weakness, fever, nausea, and vomiting, irritability and neck rigidity, diplopia or double vision. Treatment. First one is surgical. It is the mainstay of treatment. Primary aim in surgical treatment is to remove the disease and render the ear safe, and second in priority is to preserve or reconstruct hearing, but never at the cost of the primary aim. Reconstructive surgery. Hearing can be restored by myringoplasty or tympanoplasty. It can be done at the time of primary surgery or as a second stage procedure. Conservative treatment. It has a limited role in the management of cholesteatoma, but can be tried in selected cases when cholesteatoma is small and easily accessible to suction clearance under operating microscope.